Good afternoon. Very warm welcome to this afternoon's webinar. My name is Nick Hardiker. I'm a Professor of Nursing and Health Informatics and Acting Dean in the School of Human and Health Sciences at the University of Huddersfield in the UK. I'm really pleased to welcome you to this afternoon's event as part of the Nursing Research Matters webinar series, which is a manifestation of the National Nursing Research Strategy for the NHS in England. The focus of today's webinar is very much around research around mental health and very dear to our own hearts here at Huddersfield. Last year, we hosted two similar webinars showcasing a number of nursing research studies which were included in the NHS England's COVID-19 portfolio. Those webinars, we asked attendees what topics that they'd like to hear more about, and unsurprisingly, the subject of mental health was a very popular suggestion, and so we decided to go with that as a topic area. We're joined today by three excellent speakers who are leading names in the field. They'll be presenting their research and discussing the experiences of conducting research around mental health. The first speaker will be Douglas McInnes, Doug McInnes, a Professor of Mental Health at Canterbury Christ Church University. Doug will examine the qualities mental health nurses can bring to research being carried out in clinical and practice areas. The second speaker is Liz Hughes, who is Professor of Nursing and the lead for clinical academic careers at Edinburgh Napier University, visiting professor at the School of Healthcare at the University of Leeds, and adjunct professor at the School of Nursing at La Trobe, Melbourne, Australia. Liz will describe her journey as a mental health nurse, working clinically to become a nurse academic and developing a programme of funded research over the past 20 years. The final speaker will be Fiona Nolan, who holds a joint appointment as a clinical professor of mental health nursing with Anglia Ruskin University and Health Education at East of England. She's current chair of Mental Health Nurse Academics UK and chairs the UK-based Zimbabwe Life Project charity, which supports mental health workers in Zimbabwe. Fiona will talk about her work on the Mongolian Mental Health Nurse Training Project. Great speakers, I think you'll agree. But we won't be breaking between speakers, but we'll be bringing them all back again after their talks, after all three talks, to discuss issues raised by their research. I'll encourage you to pose questions or make comments using the Q&A function at the bottom of your screen. And feel free at any time to pose questions there. We'll answer them, we'll collate them and answer them as we can, as time permits towards the end. We traditionally have run out of time on these webinars, so we've left a significant amount of time for discussion. Before we hear from our speakers, though, I'm delighted to welcome Professor Mark Radford, Deputy Chief Nursing Officer for NHS England and Chief Nurse at Health Education England, who would like to make a few opening remarks. Mark.
Brilliant. Thanks, Nick, and thank you, colleagues, for joining this phenomenal event. And I just want to put my thanks out there to the team to the University of Huddersfield, who've been helping us develop these series. Actually, they're hugely popular, and I'm extremely grateful for their expertise in running events, but also, again, their kind of commitment and passion around the research agenda. So it's great to have colleagues joining us today. I think it's kind of really important for me to kind of reflect on our experiences over the last 2 to 3 years, and of course, the significant public health emergency that we still remain in the grip of in this country through COVID-19 pandemic. And my first thanks must go to mental health and learning disability colleagues up and down the country. I know how over the last 2 years, how pressured you've been in terms of delivering services, training and education, support for students, learners and trainees through your programmes, alongside dealing with the significant social disruption, as well as also impacts that we've had across the health and social care system as a result of this pandemic. And I want to thank all of our colleagues working in those sectors, because I know that you've done a phenomenal job supporting service users in your communities, particularly in terms of highlighting the opportunities where mental health and learning disability nursing colleagues provide their expertise in terms of improving outcomes for individuals and also for society and communities themselves. But also, I must thank, of course, our academic community. I appreciate over the last 2 years, we've had significant disruption to the education system. But I've always been extremely humbled by how phenomenal our academic teams are in mental health and disabilities, as well as also other branches of nursing, in support of your students, learners and trainees. I know that whilst this has been a hugely challenging time during this period, we've also been able to continue our students' journey in terms of their education and their careers, continued and moved onto online learning capability whilst providing support to your students during placements up and down the country in all sorts of different settings. So I just want to thank our academic community and our students and trainees for what they've achieved over the last 2 years. But in addition to that, I'm also, again, humbled by the impact that our research community in nursing has done in this. So it is important to stress that, research has continued during the pandemic, and our academic teams have changed their programs in many occasions. They've paused what they've been focused on, and they've refocused their energies onto issues and challenges that have arisen out of the pandemic. And I've seen phenomenal opportunities in research where academics in nursing from mental health backgrounds have examined the experiences of service users from mental health and learning disabilities and autistic people, as well as also focusing in on some of the mental health sequelae we see within our communities, but also within the nursing workforce itself. All valuable and really rich evidence that have highlighted the impact that we've had. As well as alongside this, other big programs of work have continued, and our nursing researchers have done a phenomenal job in maintaining a focus on research during this time, refocus their energies on new questions that research can help us answer during this pandemic, and also through work with the National Institutes of Health Research, done a huge amount in terms of initiating further research funding to focus on areas that we need to in terms of improving the evidence base around our decision making, both at policy level, but also importantly at practice level. I'm really kind of delighted that I'm here today to talk about how our focus on the research agenda is so vitally important, not only to our profession, but also importantly to the health and social care system, and why I believe fundamentally that the nursing community has such a strong role to play, building upon the knowledge and expertise that we already have within our research community. And of course, mental health has been at the forefront in terms of developing a research community within nursing for many, many decades. And we stand on the shoulders of giants of many previous researchers that have really pioneered approaches in terms of mental health nursing and research. And you're going to hear for some fantastic talks later on today about the kind of breadth and opportunity that nursing research will bring to this. I'm really delighted as part of this that I've always been very, very clear, society will judge us very much upon how we manage the pandemic, but would also importantly reflect on how we recover from this pandemic. So, what are our approaches going to be in terms of making improvements to society, recognizing this pandemic has really shone a light on some of the significant health inequalities that exist within our society. And more so in terms of not just the physical health, but also mental health and the inequalities experienced by those service users for learning disability services and others, I think are really important questions for us. And we're uniquely placed as a profession to support research endeavour in this area. And I think it is vital that our focus supports a better understanding, improving outcomes for those that we support, particularly in terms of our expertise as nurses, but also enriching our profession and showing a new direction of travel, building on the scholarly activity that already exists in many of our universities up and down the country. And as part of this, the Chief Nursing Officer, Ruth May, and myself, and a phenomenal group of colleagues up and down the country through wide level groups of fantastic academic teams, early careers researchers, service users, patient groups, and others have helped us develop the first CNO strategic framework for research, which was published in November of last year. Really, thanks must go to Joanne Cooper and Alison Richardson, who led this piece of work on behalf of the system. And it's published now out there and sets out a number of key priorities that I think are really important for us. We've got a deep engagement programme between now and through into the summer to really help refine this plan, recognising that absolutely this is about how do we collectively come together. And it's about harnessing the potential that exists across the national organisation. So we've been hugely supported in this endeavour by government departments such as the Department of Health and Social Care, Department of Trade, and also importantly, many other organisations, including the Royal College of Nursing. We also have the National Institute of Health Research, have all gathered around this very important strategy to really make a step change in terms of number of different areas. And firstly, this is kind of absolutely fundamentally recognising that we've got to align our efforts and endeavours around nurse-led research with our public's need. And that's in the broadest sense of recognising how those opportunities can be brought to solving some of those questions. Of course, it also is very much around making sure that we utilise the evidence base in practice. And I've written many things around evidence practice gaps over time, but what is really important to highlight is how is evidence used in practice? How do we translate that into improvements for the communities that we serve? But it is also important about releasing nurses' research potential. We've seen up and down the country phenomenal opportunities that research brings in organisations and also communities. But we have to recognise that other professional groups are moving forward more than nursing. So the strategic framework is very much around making sure that we realise that potential through careers, capacity and capability, research funding, and making sure that we have a clear pathway, particularly in terms of job opportunities, as well as also career opportunities through research to realise potential of nursing across the spectrum. And it is also about building the best research system. We recognise this as a partnership across the university, as well as the NHS and social care sector. So it is really fundamentally important about building research that absolutely taps into local communities, builds it in local systems, particularly with the new architecture around integrated care partnerships, recognising that there are other partners, including academic health science networks, other university partnerships, where we can come together to maximise the potentials to do so. But it is also about developing future opportunities. And I've talked about the framework aligning to develop new career opportunities for individuals, align funding, as well as also job opportunities across that piece between health and social care and also the academic community. But it's also about developing leadership. We recognise how important it is, both at service level, organisational level, and also importantly, at academic level, to make sure that nurses are seen as leaders in research, not just leading nursing research, but leading research opportunities in its broadest sense. And we've got many examples up and down the country where those individuals are leading, and we want to cement and develop that further to recognise their contribution. But it's also highlighting some of the opportunities that will come from research. And great that we've got some fantastic speakers today to talk about those opportunities in mental health. And mental health nursing research is such a key component of the national framework that we're very much asking colleagues from all parts and all areas of practice domain, whether they're students, early career researchers, those going through research degrees, or those working in research as research nurses and also investigators, to actively engage with this process over the next few months to really help refine that plan, so we make sure that as and when we publish that in due course, we absolutely reflect the needs and opportunities that the overarching framework brings to the research community. So thank you very much, colleagues. I'm really delighted to be here today, listen to the talks through this discussion. And of course, we've got some Q&A a little bit later on, which would be great to hear thoughts and views from colleagues who have joined us today. So thank you very much indeed.
Thank you so much, Mark, for that, providing great context. I think we traditionally get a mixed audience of practitioners and academics at these webinars, and I know that they'll all appreciate the words of gratitude, the acknowledgement of the importance of research, and actually the importance of research by nurses and for nursing, and also I'm really excited by the prospect of how we can work together to make it actually happen, and to strategy is a good thing, but actually bringing it to life is the really exciting thing. So I'm not going to prattle on any longer. I'm going to move on now. So without further ado, I'd like to introduce our first speaker, Professor Doug McInnes, who's going to talk for us for the next 15 minutes or so. And I'll see you in a little while. Over to you, Doug.
Thank you very much, Nick, and also thank you, Mark, for your very kind words as well. Just brief introduction. My name is Doug McInnes. I'm Professor of Mental Health here in Canterbury Christ Church University. I trained as a mental health nurse in the 1980s, and then subsequently did a degree and then a PhD. And I think since then, I've carried out or been involved in quite a number of different research projects, predominantly focusing on those that are looking at clinical practice and practice areas. And what I'm going to do today is talk very briefly about two pieces of recent research which hopefully give some examples of the complexities of working as a mental health nurse researcher in different areas, and also with different professional groups and different organizations. It is a very brief overview, and I'm aware there is a hyperlink to the two papers I'm going to talk about, which hopefully would give more details if anyone is interested in the particular research that's being talked about. The first research looked at implementing something called peer-supported open dialogue into an NHS trust. It was funded by the Health Foundation. The focus was on the organisation and one trust, although it did involve liaising and collaborating with various different groups, professionals, managers, clinicians, service users and carers as participants, as members of the project team, and also as clinicians within the open dialogue service that was being developed. So there was a swathe of different groups to engage with across a different parts of the project. Briefly to mention open dialogue, it's an innovative approach to working with people in mental distress or crisis that came out of Western Lapland. The focus is on dialogue and this dialogic approach, where the social network are asked to engage and talk and discuss the difficulties that are happening with the person with mental distress, and to look at developing arguments and solutions to the problems that are being found by that person. The social network includes the surface users themselves, family members, friends, work colleagues, anyone that's considered important, and also clinicians as well, working together to try and look to solve problems. The notion would be that by actually talking through the problems and not making hasty decisions, such as offering medication or offering inpatient treatment, that actually it can keep the person who's experiencing mental health problems within their community, within their work environment, and not being taken away from that. And actually it means that they are remaining part of the community for longer. There have been a number of studies undertaken in this area, but most have actually been qualitative or very small scale cross-sectional studies. There's been an argument that actually, although there's been favourable outcomes, the outcomes themselves needed to be more robust and larger scale studies needed to be done. In terms of what we did with the trust, is that firstly, there was an adaptation to ensure that it was applicable for the structures and the ways of working in the NHS. We also added to it the fact that in terms of the clinical team, that there were peers engaged in that as well. So there were service users and carers who were part of the clinical teams providing support. All the staff underwent a one-year training program, which was overseen by the team from Finland. The notion would be that social networks would start from the first contact with the person following their referral, with as many of the same members of the clinical team being involved in those social meetings and as part of the social meeting throughout their care. The referrals came through the same system as the rest of the referrals within that trust, with the slight change being that they would actually be offered the peer-supported open dialogue service as opposed to the traditional mental health service. At the initial stage of the crisis, the meetings could take place fairly regularly and last for up to 2-3 hours, with the notion that actually as the crisis subsided, meetings would be less frequent and obviously be shorter as well. All decision making would be made within these meetings, and there would be no discussions outside of the meetings, and so therefore issues regarding treatment, options and discharge would be a shared decision between all those within that meeting. The overall aim was to examine the implementation of the service in the mainstream NHS setting, and also look at a range of user and carer outcomes over the period of 6 months post engagement with the service. The design, it was an exploratory design with participants, as I mentioned, being followed up for 6 months. It was a convenient sample with all those eligible service users being invited to participate, with the notion that we would actually recruit the first 50 and then focus on collecting data from that group. Inferential stats were then used to examine differences at different time points, and at the end we had 50 service users who took part, and 25 carers already also consented to take part, although 4 of those didn't provide any data. In terms of the results themselves, I mean, this is a fairly busy slide, but in terms of the main results, all of them show to virtually, virtually totally, the fact that actually there were big improvements between the baseline measures and the first 3 months measure. And this was actually quite significant for all of these. The HONUS, which looks at health and social functioning, SWEMWebs, which looks at mental well-being, the WASAS, which looks at work and social adjustment, all improved during the course of the engagement with the services. Obviously, HONUS was only done at baseline at 6 months. But it does seem to show that there is an improvement. Now, obviously, it could well be because didn't have a comparatory group. There may have been that may have just happened naturally, but it does seem to show that there is improvement during the engagement process. The service users also completed the community mental health survey, which also showed an improvement, although less so, partly because the top score that can be achieved there is 10. So they were very, very much at the upper limit there, which I think the team thought was related to the fact that they were quite satisfied that they were getting something right at the beginning. And the last score is the carers wellbeing support score, which showed that carers were perceiving themselves as actually receiving adequate and satisfactory support from the service as well. So just in summary, just to say about the pod, this has been the first study to look at the implementation or impact of standalone pod service. And it's indicated that it can be implemented within the NHS settings, and actually that it does have positive outcomes for service users and carers. The second study is the RESET study, which was funded through a trust, but it had a number of different services involved: NHS trusts, prison service, probation service, third sector organisations, and housing organisations. The focus of the project was to support prisoners with mental health needs upon their release from prison, to try and ensure that they obtain secure accommodation. There's a wide-ranging number of research papers that have looked at the relationship between homelessness, prisoners, and mental health. The notion that there are probably 90+% of prisoners with at least one or more mental health needs has been established since the major audit conducted in the 1990s, but subsequent studies have found similar figures. There is also a lot of evidence to suggest that if people are homeless, then the likelihood is that their mental health deteriorates, and also they're more likely to reoffend. And so there is also evidence to suggest that if people are in secure housing, then it can be an important factor in reducing mental health distress and also reducing reoffending. The RESET intervention that was developed was a short-term 3-month support service for prisoners with mental health needs. It was based on the critical time intervention approach, which was something developed in the US in the 1990s to support people with mental health problems in long-term institutional care move into the community. It had 3 main elements. Firstly, to engage with the person while they were still in the institution, to identify their needs and requirements and support that they might need. Then there was a short-term intervention upon their movement into the community to ensure that they were able to move securely into the community, but also engage with services. And then the third part would be to actually remove that support so that they were engaged with the community services themselves. And that was the basis of the intervention that was developed by RESET. Following referrals within the prison, the support workers would actually meet up with service users, start on the paperwork, develop a report up to about 3 months before release. On the day of the release, they'd actually meet them at the gates, and then they would be quite active in the first few days post-release, to ensure that they had somewhere to stay, that B, they met all their crucial appointments with probation, housing, welfare, benefits, etc., and also that they had all the essentials with them in their first few days. So it would be basic things like if they had accommodation, they had some bedding, or they had a kettle, or they had tea bags. And there would be intensive work during the first week, which would gradually taper off after that. The overall aim was to evaluate the impact with the primary objective to look at the participants' housing situation. We actually recruited 62 during the course of the study and followed them up 9 months post-release. We didn't recruit directly to an intervention and comparison group. What we were aware of was that there would be a number that would be lost to follow-up or wouldn't receive the service, either because they were discharged to another prison or they were released from the court unannounced, and so therefore there would be some that would who'd agreed to receive the service and received the service and some that didn't, and so the ones that didn't would be the comparison group. We collected data at 3 time points, just after release, 3 months and 9 months post release, and then looked at inferential stats for the differences in scores between the 2 groups at each time point. We also carried out some qualitative work as well, which I'm not really going to present here. In terms of the main significant findings, I think that, well, by chance, we managed to recruit 31 to the intervention group and 31 to the comparison group. In terms, we actually found that the users were really positive about receiving the service, and 94 were still engaged. Sorry, 94% were still engaged at the 3-month time point, which was when the service was due to finish. What was interesting was there were 5 that were still engaged at the 9-month time point. In terms of, these are all significant findings. At all 3 time points, more of the intervention group were in secure housing and more of the comparison group were homeless or in other places such as prison. There were more of the reset group who were in receipt of state benefits, also in contact with the GP. And they were more likely to be in contact with mental health services at 3 months post-release as well. There were also issues in terms of significantly more of the reset group were seen as being more collaborative in their engagement with services at 2 time points, and also in just after release, less of the reset group had offended. I think that what's probably the most clearest evidence in terms of the accommodation and the impact of the intervention is that actually at 9 months post-release, the mean number of days that people were housed or had secure accommodation was nearly double in the intervention group than it was in the comparison group. And just to put that into context, that's about 90% of the time that they were being housed in secure accommodation over that 9-month period.
Could you start closing up now?
Yes, certainly. So first UK study to reduce homelessness, and the main objective was achieved, and it was seen as a very positive service. Just some concluding thoughts. I just want to mention that the research was mental health nurse led, but not mental health nurse focused, although mental health nurses were part of the study. It was very much related to clinical initiatives in the trust. And I think that part of the reason I'm being invited to be involved in that was actually establishing good links with the trust over a number of years, and actually being seen as being able to link up well with these services and having knowledge of these services and then the working environments, so that the work could be done jointly, and there would be an understanding about what the research needed to do, but also how that would work within the context of NHS environments. And thank you very much indeed.
Thank you. Thanks so much, Doug, for that great talk. We've had a couple of questions. As I said previously, we're going to leave those to the end and then bring the whole panel back together. So we'll move straight on, and I'm going to hand over now to Liz Hughes, who's going to talk to us for a little while about her own research journey. Liz.
Good, it's worked. Right, yeah, I'm going to talk to you about a sort of program of research I've been involved in over several years now, and it sort of stems from my work as a clinician in the 90s when I was working in drug and alcohol services in London. And at that time in the 90s, the focus around substance use was very much around public health and health promotion. And so it was pretty normal to talk to people about their sexual health years and harm reduction. But when I moved into a job where I was working more with serious mental illness again, I noticed safe. And a few years later, I've kind of been able to sort of pick up some of this work and start investigating it a little bit more. And also to say, this work also sits and it's generated from extensive work with people with lived experience who in various events that we've been able to hold have talked to us about their interest in this topic and their challenges in trying to get their sexual health needs met. And including in this, I cover sexual health, sexual safety, which is about sexual assault and sexual harassment, and also being able to having freedom to express their sexuality and gender within the mental health system as well. So, rationale for the research. I think that there's been a historical view that people with serious mental illness perhaps don't have relationships and don't engage in sexual activity, or if they do, it's in a high risk way. But when you look at the evidence base, they do experience high rates of sexual exploitation and domestic violence, sexual violence, as well as sexually transmitted infections, unintended or unplanned pregnancy, and bloodborne viruses. So that's not everyone, but that's the risks are higher in this group. And the theories proposed to explain this is that there are times when psychiatric symptoms become more troublesome, and that's when people may engage in more high risk sexual behaviors. And an example of that might be when someone is experience hypomania and they may become hypersexual. There's a possible link between comorbid drug and alcohol problems. I'm not saying dependency, but people using substances and being exploited when they're more vulnerable, when they're intoxicated, or swapping sex for substances. Previous experience of sexual abuse is a red flag for potential experience of sexual abuse in later life as well. Sexual stigma is a concept around where people with serious mental illness perceive that actually they aren't worthy of a healthy normal relationship, and they self-stigmatize around the mental health, and therefore feel they have very limited choices in their relationships, and maybe stick around in a relationship that's maybe not that helpful for them, but they don't perceive that they have much choice. And I think issues around social contacts and loneliness come into that as well. And finally, one of the other theories is that people with long-term mental health problems may lack some of the social skills to navigate relationships, and that might include things like being assertive about what you want and don't want to do, negotiation around whether to use condoms or not as well. So this is just a disclaimer, I'm going to be talking about a couple of studies that were funded by the NIHR, and the views expressed are those of the authors and not necessarily of those of the NHS, NIHR, or Department of Health and Social Care. So everyone has the right to a safe and satisfying sexual life, which is free from coercion and violence, and that's a human right, and that's also the World Health Organization definition of sexual health. But the reality for people is more bleak. And mental health services and mental health nurses and other professionals have not been proactive at addressing that issue. A study by McCann in 2010 interviewed people with psychosis in community mental health teams, and he found that they really aspire to have relationships, but they're much more exploitative and risky, and importantly, rarely discuss these issues with their care coordinator, if ever. I did a systematic review a few years ago looking at the rates of bloodborne viruses in psychiatric care. I think we included over 90 papers in that review, and found that all over the world you get elevated rates of bloodborne infections compared to what you'd expect in the general population. Khalifa has reported a 6 to 8-fold elevation in sexual assault in men and women with serious mental illness, and sexual assault is a real concern, as well as knowing that people who come to our services have a history of child sexual assault. We're also realizing that people are experiencing sexual assault as adults, both in the community and also within our services as well. Almost 50% of the people who attend sexual assault referral centres are also known to mental health services. And I've talked about stigma, so I will move on to that. So studies in the UK, Australia and UK consistently show that mental health staff are really concerned about this topic, but they are really worried about upsetting people, destabilising the person, and therefore that's one of the reasons why they may avoid the topic. Brooker has found that the question about sexual assault was not recorded in about 40% of CPA records that were audited. There's also evidence from Australia that mental health staff avoid routine inquiry. But there is good news that we can improve staff responses. So a study by Quinn and Happel found that training can desensitize staff regarding sex, and that improved the number of conversations about the topic. But we need more research about what would help staff have more discussions so it becomes less of an issue and more normal as well. So I'll just move on. So Fiona and I were involved in a study a few years ago now, and we did some focus groups with mental health staff. We ran 2 in the London, and then was subsequently 2 in the north in Yorkshire. And we just asked 2 main questions. What are the sexual health and relationship needs of the people you work with? And what is your role in terms of sexual health? And that's all we needed to ask, because the conversation just pretty much flowed from that. The paper's there if you want to read it in a bit more depth. But the main themes reflected the work of Chris Quinn in Australia, that really people tended not to broach the subject unless the subject was raised by the service user first. So there was no proactive inquiry. However, that said, they were aware of significant sexual health and relationship needs across the people that they work with. And there's a couple of examples where in the Yorkshire group, people were talking about not thinking about asking if someone might be pregnant before they start prescribing new psychiatric meds, which could actually be quite toxic to a fetus. The other one was where somebody had become unwell and gone into hospital in a crisis, and it turned out that they'd become very upset after having an abortion, and the care coordinator didn't even know that they were in a relationship or having sex. So conversations about relationships and contraception and all had not happened, and it was only after that critical incident that they started to talk a little bit more about what was going on. People are worried about upsetting people and being perceived as abusive or predatory. So these are really kind of worrying barriers and things that we maybe need to address with people to help staff feel better about asking these questions. And the other concern was not knowing what to do with the information. People talked about not knowing what was available in their local area, where they could signpost people to, how they could access information for their client group. And there's the systemic issues that it's not part of assessment, it's not encouraged by the system and the organisation as well. Anyway, subsequent to that, we got some funding to do a feasibility trial to trial a brief intervention that aimed to promote sexual health for people with serious mental illness in community mental health services. So a feasibility study isn't to demonstrate does it work, it's to set out whether it actually could be done, and then it sets out the parameters for being able to do a full trial. So it's a very much preliminary piece of work, but given the fact that this was the first trial of this type of intervention outside the States, then we really needed to understand, could it even be done before we spent lots of taxpayers' money on a trial that maybe would fail at the first hurdle. And I'm glad we did do that, because it turned out to be a really challenging study, and I'll say a bit more about that in a minute. So we recruited people with serious mental illness. We didn't necessarily take a diagnostic view on that. It was people who were in receipt of care in a community mental health service. We followed people, we took baseline data, and then we followed people up at 3 and 6 months. People were randomized after baseline to receive the intervention or treatment as usual. We managed to recruit 72 out of a target of 100, and that took longer than we anticipated. We needed a slight extension on that because recruitment at the start was really, really slow. And the reason it was really, really slow is that staff were really worried about this study and weren't particularly proactive at giving out information to their people on their caseloads. So we had to rapidly change our recruitment strategy to a more direct approach. And we went back to our NHS ethics and we got approval to be able to mail out information to the study, or our researchers would go to clinics and hand out information leaflets and talk to people about joining the study. And that proved much more successful, and we saw a real uptick in recruits. So the intervention itself is three times 1 hour. It's manualized, and it really is a health promotion. It's starting at a kind of fairly low baseline, but it's making sure that people have all the information they need to understand what is the issues around sexual health, improve their knowledge, talk about their own motivation to adopt safer sexual practices, which are tailored to the conversations were tailored to their own particular needs. And finally, to talk about relationships and what the qualities are of a positive relationship, and how to improve your communication skills and negotiate what you want from a sexual relationship. And that's particularly around negotiating for safer sexual practices and things like that. So the outcome was it was acceptable and feasible to offer this sexual health promotion intervention. We got good uptake, we got great follow-up at 3 and 6 months. Even in the control group who hadn't had the intervention, we still managed to retain them in the study as well. We had changes in the outcome measures. They weren't statistically significant because we didn't have enough power, but we definitely saw a shift in the right direction to some of the outcome measures, including motivation to adopt safer practices, more increased use of condoms and protection, and uptake of sexual health services as well. So the report and the main trial paper are published, and they're in the public domain, free access. And the good news is we've got funding to run a full trial, which will be fully powered, which is aiming to recruit 400 people. And there'll be an embedded process evaluation, which starts in September 2022. So we should be able to then say, does it actually work? But the process evaluation will really help us unpick what works for whom, under what circumstances as well. And I thought you might be interested to hear some of the qualitative feedback. So we had service users who worked with us on the RESPECT study, and they interviewed by telephone some of our participants for the qualitative aspect of the study. And these are some of the things that people said, that they thought it was important to take part. It's an important topic. They thought it was interesting. I felt I needed to brush up on a few things. So people were kind of feeling like the content was right, and they did need a refresher. And again, the third comment is about it's educational, improve my knowledge. I hadn't really studied it or looked at it in detail since school. And importantly, people were starting to have more conversations with their care coordinator following taking part. And that's something we really want to look at in the full trial, is what's the impact of raising the profile of this topic on broader care conversations. So I'll just talk to you a little bit about a second study I've been involved in, which followed on from the RESPECT study. This is a MEMO study, which was looking at the effectiveness of sexual assault referral centres in meeting mental health and substance use needs of people who attend. And we did it's a 5-stage work package. We did a review, a national survey, prevalence study, case studies, routine data, and we're developing some tools and dissemination products to inform commissioners and providers. This took a realist approach. So it wasn't a trial, but using realist methods to identify what works for whom, in what context and how. And we basically synthesized information from a variety of sources, including qualitative and quantitative and documentary analysis. So it's just finished. It finished last autumn. We needed a slight extension because of COVID delays. The report is submitted, and we're tackling the peer reviews at the moment, and we've got papers about to be submitted. So it's very much kind of fresh off the press, and We're hoping to run a dissemination event in July 2022, which will be in person, dates to be decided. So if you follow a Study Memos, if you're interested in that, and we'll be tweeting about progress on that event, and there'll also be opportunity to join in remotely as well. So
hi Liz, just
yeah,
a couple of minutes, please.
That's fine. So systematic review showed us that there was limited evidence on what works on mental health and substance use at a sexual assault referral centre. That was looking at global research. We found in the national survey there's very limited mental health staff who work in SARCs, assessments very variable, and poor pathways into mental health. The prevalence study, we use screening tools to for people who attended SARCs, and we found really high levels and significant mental health and substance use need in the people who attended. Case studies, we found a real positive impact when you did have someone. I mean, it happened to be clinical psychology, but you had a mental health professional working in the team and providing some in-house work support. The survivors thought that was really helpful, and it also had an impact on staff confidence and skills. And the secondary data analysis, which looked at CRIS data from the South London and Maudsley, which is an anonymised routine data set. We identified people with sexual assault in their notes, and we compared them with a group who didn't have that, and they had more needs at baseline and had more intensity of services, but made similar improvements. So people might look more complex, but do as well if as people without those that have additional trauma. And that's some references. And just to follow us, this website's there, and I think there's been some information in the chat. But Memos has got his own Twitter, and that's mine. And also I've been involved in Queer Futures too, which is looking at the common mental health needs of youth, LGBTQ youth as well. So thank you very much for inviting me, and yeah, that's me done. Thank you.
Thanks a lot, Liz. We've had again another couple of questions, which is great. We'll address those at the end of the three talks. And the questions about slide sharing, we will be sharing slides with the approval of the speakers, and the recordings we'll go through a process of captioning to increase accessibility. Hi, so we'll just move on now straight away to our final speaker, hand over to Fiona. So over to you, thanks.
Thanks, Nick, and thanks very much everybody for inviting me this afternoon, and I hope I can do a good follow-up to the previous two speakers. It's a real pleasure to be here with them. I'm just going to try and do the first piece of tech now and share my screen. Okay. Let me go back. Okay, I'm going to change the scene completely now and talk about Central Asia. So moving on from research conducted in the UK, I want to talk not about a research project, but about an educational program that's been nurse-led and has just completed in Mongolia. And I think the main focus of this talk will be to see the relevance of this work for nurses in the UK as well as in Central Asia. So this, I go on to the next slide. We've called it working in a low to middle income country, and I'm not sure if people are familiar with these categories, but just to let you know what a low middle income country is, the average national income is less than $4,000 per year. This was in 2017 when we were putting in an application for this project. So it's really tiny, and nurses fall into a category of around $200 US income per month in Mongolia. The population is very small. It's the lowest density populated country in the world, huge geographic area, and most of the population is in the capital of Ulaanbaatar. And life expectancy is almost 70 at the moment, but not so recently. It was in the 50s because of the diet, because of pollution, and because of the huge adversity in the climate, where it goes down to -40 in the winter. And I've had the great pleasure of experiencing that myself, at -37 in the capital city when I was there for work. Sorry about the blurred image here, but this is where it is, just in case you're not familiar, and I wasn't. I was on the plane over to Mongolia for my first visit in 2014, and I wasn't really sure where it was, but it's strategically placed between Russia and China, landlocked, and it has huge natural resources, which is why I went over there initially as part of an NHS delegation in 2014. And we were led to believe that it was going to be a very rich country and could pay the NHS for consultancy in developing their healthcare services. Unfortunately, the mining contracts weren't signed for many years, so we didn't actually get those consultancy contracts to bring back to the UK. But it still sparked my interest and the interest of other colleagues in working together with nurses in that country to see what we could change in their existing structures, in their existing care delivery, and how we could exchange our knowledge. So I have a series of pictures here, just to instead of p-values and research findings, even though I am an academic. This is the capital city, Ulaanbaatar. As you can see, it's ugly, it's smoky, it's the most polluted capital city in the world in the winter, and very high mortality rates, particularly in infants, due to the pollution. And this is the mental health workforce per 10,000, and Mongolia is right here, if you can see, in the corner. So the lowest numbers per population of psychiatrists and mental health nurses, according to the World Health Organization Atlas in 2017. There's been another mental health atlas since, and the figures have changed. But of course, this isn't the total workforce. If you look at the UK here, it looks like the UK have a lot less in the workforce than, say, Finland, which isn't true, because this doesn't take into account psychologists, occupational therapists, and healthcare assistants. But in Mongolia, there are no occupational therapists, there are no psychologists, and very few healthcare assistants. So this is the workforce in itself. So very sparsely resourced mental health services. Another picture for you. This is a picture taken in the one big mental health hospital. They just have one big old asylum in the capital city of Mongolia. This is a typical patient bedroom. And when we took that photo, I think there were 6 patients on those beds who were asked to jump off and let us take the picture. There are no sheets on the beds. And it looks, it looks pretty poor. But I stayed in student accommodation in Mongolia, which was very similar to this. So I think that looking through the perspective of a low-income country, the rest of the population isn't much better off than the patients in these hospitals. So what the program I want to talk to you about is funded by the European Union. And apologies for mentioning the European Union now post-Brexit, but we were able to apply for this funding at the time in 2017, 2018. And it was the Erasmus Plus funding scheme that we accessed. Some of you may have heard of it. I myself was an Erasmus student in the 1990s when I was doing a politics degree, and used Erasmus funding to go to France. But we applied under the capacity building and higher education funding stream, which aimed to strengthen the skills of university staff. And at the time, we were very well positioned as a nurse-led project, very unusual to have healthcare projects in this, in Erasmus Plus, but this was nurse-led. But there was a growing recognition of the global crisis in numbers of nurses, numbers of registered nurses in the workforce. And we were lucky that our project was one of the ones that was successful at that time. There's about a 10% success rate in applications, and we're competing against astrophysics, against geographers, against social scientists, against every other type of faculty in all universities in Europe. But we were one of a tiny handful of nurse-led programs across the years to be successful. We got €1 million, and I led the project from the University of Essex, where I was employed at the time. And these were the aims. So they were very basic aims, but if you look at them and try and think, how were we going to demonstrate that we had achieved those? And that was tricky. So as I said, this wasn't a research project, it was an educational project, but having an academic background myself, I was thinking, oh, this is going to be tough. How do we demonstrate that we've addressed the stigma in Mongolian society, that we've raised the status of nursing? We didn't have any baseline. So all we could do is report anecdotes, but we had these fairly high aspirations for the program. And the partners, according to the criteria for the program, you needed 3 European partners. And I had established relationships with colleagues in Finland and in the Netherlands through the European Conference, the annual European Conference on Mental Health. It's a really good networking opportunity. And I met colleagues there who collaborated on this. We also needed 3 Mongolian universities, or 3 universities in a low-income country. And because of my established relationships in Mongolia, that was fairly easy to access. We had associate partners, some based in the NHS, South London and Maudsley. NHS Foundation Trust was one, Barnet Enfield and Haringey in North London another. And we had associate partners in non-government organizations in Mongolia. So it's kind of, that was the start, and I'll go right to the end without telling you about what happened in the middle, but it was grueling and it was tough, and it was very, a lot of input and administration, and it was the most challenging thing I've ever done in my career, but also the most satisfying. So we managed to collate the curriculum for mental health nurses from 7 countries. That included Canada, Ireland, UK, Netherlands, Finland, Australia, Mongolia, and some other small curricula from some of the Central Asian countries. We put them all in a pot, and we looked at what was what overlapped and what we thought would be useful in Mongolia as a representative of a country that did not have any mental health formal education for nurses. So nurses graduated as general acute nurses and went to work in mental health settings without any formal education, and some in-house training afterwards, but none that was accredited. And Mongolia isn't unusual in that respect. I mean, you're probably aware that the UK is only one of 3 countries in the world that has a specialist undergrad program for mental health nursing. We're a real outlier in that respect, and we're not in line with the rest of the world. However, most other areas, particularly in the developed world, have postgraduate programs, whereas low-income countries tend not to. Mongolia is one of those. So through this, through a fairly robust process of consultation with groups in the UK, consultation with the partners in Mongolia and the project partners, we narrowed down the topics that we thought would be useful in a 6-month postgraduate curriculum. And we identified 5 overarching modules. Now, the curricula is available on the website, and I think that the website is going to be put in the chat for you later. It's all in the public domain. But the main focus, which was very new to Mongolia, as it would be to many low-income countries, was a focus on recovery, the recovery program, on the rights of service users, involvement of service users in their care, and reduction on restrictive and coercive practices. And another thing that was very unusual and new to them was the role of the nurse in decision-making in care, because it's very hierarchical. The healthcare system in most countries is hierarchical, and in Mongolia, it's somewhat reminiscent, I would imagine, of the UK 50 years ago, where in meetings, nurses tend not to speak if their medical colleagues are present. And the only writing that nurses did at the time I started working in Mongolia was to sign a medicine chart. So the ability of nurses to write reports and for their opinions to be taken into account in patient care was very underdeveloped. So in this program, we conducted it over 3 years. And during those 3 years, we had 50 sessions in the 5 modules that were co-facilitated by Mongolian colleagues and colleagues from the English-speaking world. All of these had to have interpreters present. Mongolians don't speak English. That was one of the huge challenges that we faced. So interpreting was a big cost to the project and had to be adequately financed. So we did 50 co-facilitated sessions, and then we got engagement from 33 colleagues, gave their time voluntarily to teach, in their areas of expertise, along with Mongolians, to to really make this program something special. And I know Liz is an associate professor at one of the partner universities that we engaged, La Trobe in Australia. And we had people from all over the world contribute for no pro bono, just voluntarily with their time. So at the end, we finished it last November. We managed to create this 6-month postgraduate course. We recruited 24 students who were all registered nurses already working in mental health settings, 19 of whom completed the course. Then just prior to the pandemic, 15 people from Mongolia visited London, and that was due to be a big part of the program, was to for the Mongolians to have sessions in London, shadowing and visiting clinical areas. Unfortunately, it wasn't possible since COVID, so about half of the project funding couldn't be released due to the inability to travel. We've had publications just since the project finished in peer-reviewed Russian and Mongolian journals, which I don't think we'll put we can put the links if you like, but I must say I have difficulty reading them myself. And in terms of research to look at how was the project effective, okay, we have an output, we got the course, but to see its effectiveness in terms of clinical care delivery, reduction in stigma, raising the status of nurses, we haven't been able to do that because we didn't have a baseline, but it's something that we're planning to do. But we did a training needs analysis before and after the project, and we found significant improvement in the ability of clinical and educational staff in their confidence in delivering a recovery-focused teaching and care, and also involvement of service users. Students evaluated each session and their modules as we went along, and we have very substantial data in that respect, but they're a very polite nation, and all of the scores both before and after, unfortunately, were extremely high, so it didn't show any difference of sessions before they did their 6-month training and then after. So I'll wrap up quite quickly because I know we're a bit short on time, but just to say this was a hugely challenging program. I don't speak Mongolian. Nobody I met in Mongolia spoke a word of English, and we had to go through hired interpreters who were unfamiliar with the industry. They were unfamiliar with the healthcare environment. So that in itself had difficulties. The culture was very different, and cross-country communication. Our colleagues in Finland were speaking through English as a second language, and in the Netherlands as well. So they were the main challenges. However, we managed to review curricula in mental health nursing from many different countries. We got agreement on the content of a postgraduate course following months of negotiation, and we managed to engage so many experts in the delivery. Now, the relationships that were built in the course of this 3-year project and beforehand, I think will be sustained. But to my mind, the confidence of the nurses involved is the main achievement, and the ability of these nurses in Mongolia to realize that they have a voice, that they can now lobby for increased involvement in decision making. The project is on the radar of the Ministry of Health. The Minister of Health has opened and closed some of the sessions that we've had. We've had substantial involvement from the British Embassy, who have held our hand along the way, as they should do, because this is business for Mongolia. But I think the status of nursing, this is anecdotally, and I don't have any evidence to underpin this, but I feel that it has only benefited from this project. We've had many TV interviews, we've had radio interviews, and for me as a nurse, to be leading an international project is something that is still quite unbelievable in a country where nurses have such low status. So I think role modeling and engaging nurses in international work has been good for us in the UK and in Europe, but also in Mongolia. So what are we going to do now? We've translated some validated measures, through forward back translation, through a fairly rigorous process, and we're planning to do a national survey of workforce well-being, which is going to be run by one of the partner universities in Mongolia and linked to Anglia Ruskin, funded by Anglia Ruskin University, doing a cross industry comparison of the mining industry, healthcare, and other industries on job burnout, job satisfaction, and we also hope to do some work on the impact on patient care of people who've been involved in undertaking this course. A big thing is that the content of the postgraduate course is in the public domain. It's paid for by European taxpayers, so it's now NHSEI has agreed that it would be a foundation course for all international recruits to mental health services in England, and we're in the process of refining it so that it should be fit for purpose to include UK mental health law, safeguarding things that hadn't been included up to now. So we would hope that would be available for all trusts in the UK to use within the next few weeks. So I'll finish on another picture, but sorry to be bringing you through such a huge program in such a short time. Thanks very much for listening.
Thanks very much, Fiona. Wonderful talk, as were all of the others. Yeah, all with similar tales of kind of seeing an issue, tackling it, and then revealing the impact of the work. So I'll just invite all of the panelists back into the room, and we'll go through some of the questions that have come through. Thank you for posting the questions. We've got a fair amount of time, about a quarter of an hour, to go through questions. Some of the questions are really quite specific to projects, and I think we'll deal with those offline. Perhaps you could email the project leads. But what I've tried to do is to kind of embody the questions into larger questions, more general questions, if you like. So my first question, I think it was stimulated while Mariam had posted a question about potential project around influencing the influence of consultation time on effectiveness, something like that. I may have got it wrong, sorry, Mariam. And then there was another question by an anonymous attendee about visibility of ADHD. So my question, I think, and I'll pose it first to Liz, is around how would you suggest people should get off the starting blocks? How do you go from curiosity to actually initiating something that could turn into a project?
That's a good question. I suppose all of us can reflect on where we started, and I think it starts with a good clinical curiosity and spotting something that's not quite working well, but also talking to people with lived experiences about their challenges and what they want, and sort of ideas start formulating. But the best place to start is to really kind of connect with your local R&D department, because there may well be projects that are going on that you could have some sort of shadowing role in, or just to get a feel for kind of how these studies might work. And there are Health Education England internships that you can apply for backfill time. And some organisations also have their own internal schemes as well, where you're kind of bought out of your clinical role and you shadow a research project and have an academic mentor. The other thing is, I would always suggest people think about getting some sort of research training, and that might be a master's in research. Or doing a master's dissertation that's research focused, which is a really good, gives you some basic skills and understanding of the process as well. But really getting out there, networking, thinking about what you're interested in, and finding people who are doing that stuff, and kind of offering your clinical expertise to that research world, really.
Okay, thanks very much. So we'll look a bit deeper into research careers in the next question, but Fiona, in terms of this kind of idea to project, any tips for people that you could add to Liz's insights?
I completely agree with everything that Liz has said, but I think it's worth exploring, as well as you're going to your local R&D department, whether your chief nurse, the senior leadership team has identified anyone within your organization as a research lead, either for allied health professional or nursing. And if there isn't one in your organization, there will be one in your region. So someone to provide mentorship, even that initial chat with, is important. And I think lobbying your chief nurse as well, and this I think comes into the CNO strategy, to create opportunities for people to do secondments in research posts. That's how I started, and maybe Liz started as well. A 6-month research nurse job, just to to see what it's like, you know, going from a community nurse to something completely different. I had that opportunity, and creating those opportunities is possible through liaison with the Clinical Research Network, who already fund a lot of posts in trusts, and use of research capability funding within trusts. So I think working with the chief nurse and approaching the chief nurse to say, how are these opportunities developed, or how are you going to develop them in the organization, would be useful.
Okay, thanks for that. I'm going to, rather than round robin and talk to Doug about what he thinks to add to that, I'm going to ask him a slightly different question, but it does follow on. And there's been a couple of questions essentially about research career pathways or routes into research. So I'm going to ask each of the panelists in turn something about their own journey, but also a top tip that you would, your golden nugget of advice that you could give to people to walk away with. And then we'll circle back to Mark, and he can maybe talk about what the strategy is putting in place to support that both engagement with research and also capacity to deliver research. So Doug, if you could kick off in terms of your own research journey and how other people might use something that you've learned en route.
I think my research journey started when I did my undergraduate degree. I was still working on wards at the time, and as part of that degree, I actually had to do a research project, and it stimulated me on two levels. One, because I think it was an interesting topic, and secondly, because it gave me valuable information and gave the ward that I was working on at the time valuable information as well. And from that, I was able to develop skills, basic research skills, which I could then take forward. The actual topic was looking at carers, people with schizophrenia. And actually that then led on to me doing my PhD in that area. I think the notion of actually developing research skills, either through experience as a research nurse or having a research post, or through academic qualifications, is really important, because I think it shows that there's competency there. It also shows you've got some skills that you can then bring to bear in different situations. So I think that ability to develop those skills is really important, and there are opportunities now. That could well be within the workplace, or it may well be through academia. I suppose the other element, just to say, is that I found after PhD, I had this vision that the research world would suddenly open up to me, and I'd be sort of flooded with offers. Whereas in fact, what I found was that actually I had to go and link up, particularly with practice areas, and to link up with people who were already doing research and actually form those links. And form those collaborations, and from those collaborations you actually get to form bigger networks, and there are more opportunities. The other element about that as well is that you get to identify what are the areas within practice areas, within trusts, that are actually important, or where there is a lack of evidence, or where people are wanting to develop, so that you become much more aware of those opportunities. And I think that you know, once you find, the other thing is that once you find people who are interested in research in those areas, it's worthwhile just, you know, hanging on to their coattails, especially when you're a neophyte researcher, because they will offer you the opportunities. And what I found is that most people, especially if you're on the top of the tree, are more than willing to actually to offer support, offer advice, and actually to give you opportunities as well, which you can then develop.
Thank you. Could I ask Fiona for some top tips next?
Yeah, I think get a mentor is the main thing. I think both myself and Liz have benefited enormously from one individual, and that was Professor Sonia Johnson in University College London. And she is the one who's, well, I think single-handedly dragged us into an academic career by giving us opportunities, because at that time, you know, 20 years ago, we didn't have nurse role models, and we didn't have nurses in positions to offer us those opportunities. So I would still be in favor of this cross-professional fertilization, and I would really encourage mental psychiatrists and medical colleagues to engage their AHP and nursing colleagues in their research, but Now there are more people like myself and Liz. Approach them, ask them for mentorship, informal, shadow. Liz has really big projects going on. Ask if you can sit in the meetings, you know, just even without that role as a research nurse, just to try and absorb through some kind of osmosis, just the research language. So that's as a first step, I think, in a nutshell. There's plenty of other things, and Doug has mentioned those, but mentorship and shadowing, I think, are important.
Yeah, I think you're right, and I think people welcome the opportunity to guide other people as well. And so you know, there's nothing to be afraid of, is to ask people. It's not making a nuisance of yourself at all. So Liz, and then we'll turn to Mark.
Oh, can you hear me? Yeah. Yeah, everything Doug and Fiona have said, I absolutely echo. And yeah, and also Sonia gave me my first job in academia for, there was a big trial of an training intervention for people with mental health problems in South London and Maudsley. And she was one of the lead researchers in that. And I got recruited to do the training. So I wasn't recruited to do the research, I was recruited to develop and deliver the training. And then I just became part of the research team. So that was quite a big jump from being a clinician to suddenly being in an institute psychiatry massive research group. And I learned so much from literally just watching and listening and observing as well. And then I did my PhD on the back of that. Which was really great. And I think I valued being in a place where there was other mental health nurses doing similar things. So at the time, at the section of psychiatric nursing in Institute Psychiatry, there was quite a few of us and various points of our PhD and academic and teaching journeys. And that was really great. Because you realised that it was possible, because I didn't have a clue what a PhD was when I started one. So I didn't even know what shape or size it was or what you could do. So knowing that and demystifying it was great. But the other thing, just to add, is being entrepreneurial and spotting gaps in the market. And that means sort of finding your own topic that you become you have some sort of expertise on, that has a sort of programmatic feel, that you feel that you become, that really helps and just separate yourself out and forge your own path, and being savvy to what's important in terms of a policy direction, because the NIHR, who's our biggest funder, wants to fund stuff that makes a difference to the NHS and patients ultimately, not about our careers. So it's about thinking about starting with what's important for patient outcomes and work backwards, and what's not been done and where the gaps are, and being prepared to switch from something that you thought you wanted to do and being able to switch, thinking about how you've got translatable skills. So don't get fixated on a particular area, be agile to how things change. I mean, COVID's taught us that as well, how we've had to change how we work, and also what we look at as well. So
that's great. I forgot to mention at the very start that I'm also a registered nurse, and one thing that I'd add to this, part of me has been very active in my research career. Part of me has been entirely passive, but what I have done is I've learned to say yes to things almost blindly. I've just, where opportunities are presented to me, instead of going, oh, I'm not sure about that, when I'm thinking about what renovations to my house or something, I start biting my nails. Actually, with research, if someone presents me with an opportunity, I've said yes, and very rarely regretted it. So I would get that kind of grasping opportunities mindset. So I'll hand over now. I think we'll go to close now with Mark talking about perhaps how the strategy and the kind of streams within the strategy can support this kind of engagement with research, but also treading on the pathway to an academic research career.
Yeah, thanks, Nick, and what brilliant advice from colleagues around things. And I think one of the things to reflect on is that the current experience of navigating a clinical academic career in nursing is really, really tough. Actually, I think you've heard that a lot from colleagues. You know, my own journey you know, through to PhD and other research sectors has equally been challenging. But other colleagues have said, actually, there have been so many generous people along the way who have given me encouragement at the deepest, darkest moments when you think, is this really for me? You know, and a kind of an example and a shout out to somebody that during my PhD, I contacted 3 utter legends in the research community, Sam Porter, Davina Allen, and Joanna Latimer. And they all gave me time to go and visit them and spend hours and hours and hours discussing their work and my theories. It was just immense that these phenomenal researchers were so engaged in encouraging people to come through the research community. So don't hesitate to get in touch with leading academics to talk about your ideas and their work, as well as also look for opportunities. And there are many. It is tough, but there are many. We've got loads of organisations like NIHR. Liz has mentioned in terms of the, you know, the direction of travel around funding, being agile in terms of your expertise that you bring to that. But again, seeking out opportunities for early careers opportunities, moving from being a research nurse and doing an MRes program. We've got many examples across the country where they're very, very competitive, but they're brilliant ways of getting you the skills and knowledge and getting you that step forward. There is also funding for research PhDs at university level, as well as also other national programs. So seek out opportunities in your local environment, and often the resources follow the idea. So, you know, I've found research funding for individuals who want to do a PhD because they've actually got the idea, and we've identified that through university support. But there was also the Council of Deans. They do a huge amount of work around kind of opportunities for research placement. They've got networks, again, building researchers into that kind of community. NIHR are doing that. But of course, the research strategy and framework is going to try and knit all of that together to make life easier for researchers to identify ideas and opportunities, to start to work with research teams, and also importantly, to make sure that there is an appropriate and really robust career trajectory with both funding and opportunity, right through from that idea, right through to those kind of most senior academic appointments are really clear. And some of that is really practical. It's like making joint job roles work between the NHS and universities, because at the moment they're really tricky to land. They work for medics, but they don't work as well for nurses. You know, how many MRes are available, and how do we get those opportunities to do that? How do research nurses move from supporting research programs into their own research? So the framework is really about setting out a number of key actions that look at the national frameworks, the opportunities, the funding, and then sorting out the kind of list of things that make life difficult, and try to deal with the barriers that Liz, Fiona, Doug, and yourself, Nick, have probably had to navigate the complex system over time. So lots to do, but thank you very much for joining today. And I think I'm handing back to you, Nick, for a final close.
Yeah, thanks very much, Mark, for your insights, and thanks just to all of the speakers, to Doug, Liz, and Fiona. And thanks also to NHS England for having the foresight to put on this event in the first place. There's a link, you will find a link in the chat to a very short evaluation. If you could just spend a couple of minutes filling that out, we're very grateful. Honest feedback, always welcome. And we use the survey, as you've seen, the reason that we're focusing on mental health today is because of the findings from that survey. I hope you found it informative. I hope you're leaving with a sense of enormous pride, particularly in our wonderful profession, and the curiosity to get more involved, more engaged in research in nursing. So on behalf of the School of Human and Health Sciences here at the University of Huddersfield, and on behalf of NHS England, I'd like to thank you for coming along today, and I hope to see you at the next event. Take care and a very good afternoon. Thank you.